Ma'am, please start. Thank you.
Yeah. Good evening and a warm welcome from Maharashtra IAP and MahaIAP Women's Committee to all the dignitaries, moderators, esteemed speakers of today, Dr. Sagar Wagh sir and Dr. Deepa Firke ma'am, who have accepted our invitation to share their expertise. A welcome to fellow pediatricians and all viewers from across the state who have logged in for yet another interesting academic session of Thursday Thrills. Monsoon Special Febrile Illness, which has been organized by our MahaIAP and MahaIAP Women's Committee 2025. Myself, Dr. Ujjwala Gavli, I'm an EB member of IAP Sangli City and an executive board member for MahaIAP Women's Committee West Zone. I'm very grateful to President Dr. Sanjay Pakmode sir, Secretary General Dr. Amol Pawar sir, Convener Dr. Sanjay Deshmukh sir, Chairperson of MahaIAP Women's Committee Dr. Jayashree Shivalkar ma'am, who has given me this opportunity to be the host today for this monsoon special Thursday Thrills. With the arrival of monsoon, the environment changes to lush greenery and cooler weathers, and we get a relief from the summer heat. But along with this beauty, the rainy season favors the growth of bacteria, viruses, parasites, leading to a surge of illness ranging from waterborne infections like diarrhea and typhoid to mosquito-borne in diseases like malaria and dengue, and respiratory illness such as viral fever, flu, pneumonia, which continue to be a major challenge in our practice. Children are more vulnerable during the season because of their developing immunity and frequent exposure to this contaminated water and tendencies to play outside in rains. Today's session has been specially planned to update and equip us with the latest knowledge in the diagnosis, the management, and prevention of these febrile illness. Our speakers today will be sharing practical insights and evidence-based strategies that will help us deliver better care to our young patients during this vulnerable season. Before we start the academic session, it is my privilege to extend a warm welcome to our respected MahaIAP President, Dr. Sanjay Pakmode sir, and we are honored to have you with us, sir, today, and your presence and guidance will inspire us. So I now request Dr. Sanjay Pakmode sir to kindly address the viewers.
Namaskar. Welcome to the Thursday Thrills. Now, these 3 days we are having continuously the MahaIAP activities. Yesterday only we were having activity Smart Pediatrician with Dr. Samir Dalwai on the finance. Today the Thursday Thrill and tomorrow the Friday Ka Punch. So on the Thursday Thrill, a special activity of the Women's Wing is really a encouraging activity where so many topics, systems are covered under this particular heading. Now being the monsoon season, we have chosen the topics which will help the attendees in rational practicing, in a rational approach to the few diseases which are very common in the monsoon period. And just now we are also in the vaccine somewhat, we have covered dengue vaccine with the Nitin Shah sir last month only. Now today's topics means presenters Dr. Sagar Wagh, which is he's presenting with the fever with the rash, and Madam Deepa Firke presenting the updates in the dengue. Now rash, I understand somebody has said if you are a junior and you are saying rash, you're a happy person, because you know this is a rash which can be managed with H1, H2, H3 with local calamine. But as you get bald and your hair get grayer, then you come to know the rash is really a very difficult thing to diagnose and to manage. Because with the fever, without fever, it may be from infectious disease to autoimmune disease to simple skin rash. The second topic covered by Deepa madam, that is updates. We know dengue we are managing either on the OPD basis, having a very mild manifestations and can be managed with the symptomatic medicines. But at the same times, a dengue which can land in ICU and we may need level 3 care or tertiary level care. Now in that, why we need the dengue updates? Because we know this, as Dr. Y.K. Amdekar says, medicine keep on changing. Science is not a constant thing. Whatever said today will change tomorrow. Initially in the dengue, we are talking of the fluid. Now again, we are coming to the restricting fluid. So let us hear from two experts today the fever with the rash and updates in the dengue. I welcome all of you, especially the women's wing, Jaya Madam, chairperson of the women's wing, then the Sandhya Madam, Ujwala Madam, and our dynamic secretary, and all the Sanjay Deshmukh convener and MahaIP EBs and all other CIP EBs who have joined for the today's program. So let's learn from the experts about the two topics. Over to you, man. Ujwala ma'am.
Thank you, sir. Thank you for your opening remarks. And now it's my great pleasure to welcome our Dynamic Secretary General, MahaIP Dr. Amol Pawar, sir, for his continuous efforts for the growth of our association and the academic activities. And we look forward for your motivating words and valuable guidance. And please guide us for the opening remarks to address the view.
Thank you, Ujwala ma'am.
Dr. Amol Pawar, sir.
Yes, thank you, ma'am. First of all, warm greetings from Maha Academy of Pediatrics, Maharashtra branch of Indian Academy of Pediatrics to each one of you. And in attendees, I can see from USA, Dr. Srinivasan sir, our mentor since since last 3-4 years, he had joined, especially from USA, and he always keep on learning and sharing the knowledge to all of us. So both the topics are very well chosen by Women's Committee, and we know since last 3-4 years we have been seeing the growth of Maharashtra IP Women Committee under various our leaders like Dr. Renu Goralkar, Dr. Sonali Shirbate last year, Dr. Manjusha Sherkar, and this year another dynamic lady, Dr. Jayasri Shivalkar ma'am, Amog ma'am, and Kashmiri, and all the women committee members. They are very much into academics, and they are continuously doing the various programs, academic programs or social programs. They are giving lectures to various for adults and children, and Jayasri ma'am being developmental pediatrician, she is carrying out various social activities and community activities as well. So this year is full of activities by Maharashtra IP Women Committee. And today's speakers, Dr. Sagar Wagh sir, dear friend, and also Dr. Deepa ma'am, my co-AB and very vibrant executive board member of this year from Maharashtra to Central IP. And just now, 3-4 days back, we were in Pune. She was she was the main coordinator of Maharashtra IP program of PG teaching activity at Sassoon Hospital with Dr. Aarti Kanikar ma'am, Dr. Uday Rajput sir, and all the BJ Medical. This thing means many of the PGs from Gondia, Chandrapur, Dhulia, then Nasik, some parts of Mumbai, Pune, Kolhapur, Miraj, and various almost they have curtailed the numbers to 42. And there were many entries, but they have to refuse entries this time. And the main coordinator being Deepa ma'am, it was a very wonderfully conducted activity at Sassoon. So I wish all the best to both the speakers and wish you all happy learning. And just I will request Srinivasan sir, he will be very brief, I know, but still I want to hear some words from Dr. Srinivasan.
Why me? I am thankful that you are allowing me to come and listen and learn. Thank you so much. And I always enjoy listening to stalwarts from your platform. So you are doing a great job, your whole team. Congratulations. Thank you.
Also, welcome to Dr. Jitendra Gawane sir, Dr. Sanjay Deshmukh sir, and all the attendees. Over to you, Ujwala ma'am. Thank you, Srinivasan sir. Thank you.
Thank you, Dr. Amol, sir.
Be there till end, sir, because we will need your guidance to attendees. Thank you.
Thank you, sir.
Thank you, Dr. Amol, sir, for your words of gratitude towards the work done by the Women's Committee. And I'm now also privileged to Dr. Jaya Shivalkar ma'am, the esteemed chairperson of MahaIP Women's Committee 2025, whose active leadership and constant encouragement has always been the strength for our academic activities. And we sincerely acknowledge and appreciate her valuable support. And also warmly welcome Dr. Sanjay Deshmukh, sir, for the convener, for being present over here. I now take this opportunity to warmly welcome also our moderator for today's session, Dr. Sandhya Kondapalli Madam. She's a consultant pediatric endocrinologist and HOD Department of Pediatrics at Manik Hospital, Sambhajinagar. She's also the zonal EB member of Maha-AP Women's Committee of Marathwada region and been a PG guide for DMB and DCH students. She has been the past secretary of IAP Aurangabad, and she's also a co-author of IAP textbook on pediatric endocrinology. She's been a speaker in various regional and state conferences, and her area of interest are growth and glucose metabolism. Sandhya ma'am, we are grateful to have you to guide us and moderate this academic program on febrile illness in the monsoons. The goal of this session is not just to understand the disease, but also to strengthen our clinical acumen and update our knowledge, and to reinforce the evidence-based practices which our esteemed speakers are going to convey to us. So let us make this session interactive, fruitful, and impactful, and request all the viewers to please post your queries in the chat box, which will be addressed by the speakers. I now request Dr. Sandhya Kondapalli Madam to proceed for the further proceedings.
Thank you, Ujjwala Madam. Thanks for the kind introduction. I will like first of all to thank all the dignitaries of Maha-AP Women's Committee, particularly Dr. Sanjay Pakmode sir, who is our president, Dr. Amol Pawar, who I know him as a very dynamic Secretary General of Maha-AP, Dr. Sanjay Deshmukh, who is a convener, and particularly respected Dr. Jaya Shivalkar Madam for giving me this opportunity to moderate the session, which is a very, very important topic, particularly in monsoon. As a pediatrician, we all know that fever is really, in all senses, it is a hot topic. Hot for parents also, hot for children also, and hot for the pediatricians also. Particularly in these heavy monsoons, we are facing a lot of acute febrile illnesses. And many times we are facing with the diagnostic and also therapeutic dilemmas also. So we will definitely like to know the recent advancement in these fields, and we will have many answers to our many queries also. So with this introduction, I will not waste any time, and we will just start with our core program. First of all, I will like to invite Dr. Sagar Wagh. I will briefly introduce him. Dr. Sagar Wagh is a private pediatrician. He is doing his pediatric practice since last 20 years in Ahilyanagar. He is a director of Wagh Nursing Home, Ahilyanagar. He is pediatrician and neonatologist with a special interest in pediatric allergies. He is also doing a practice of pediatric sleep medicine. He is ex-EB member of Maha-IAP, and he is EB member of IAP Allergy and Immunology Chapter, Maharashtra branch. So we have here a very right person to talk on fever with rash, which is our first topic. So I will request Dr. Sagar Wagh to share his slides and start lecture. One thing I will like to request both the speakers that please, if possible, they should restrict their speech to 30 minutes so that we can have good time for the discussion further. So over to Dr. Sagar.
Yes, thank you, madam. I'll just share the screen. Share. Click. Yes, he can. Can you see this screen?
Yes, sir.
yes.
It is
Yes, sir, we
visible.
can
It
see
is
it.
visible.
It is visible.
Yeah,
Yes.
yeah. So at the onset, I sincerely thank Dr. Sanjay Pakmode sir, President Maha-IAP, Dr. Amol Pawar sir, Secretary General Maha-IAP, my friend Dr. Sanjay Deshmukh, Convener Maha-IAP, Dr. Jayashree Shivalkar Madam, Chairperson of Maha-IAP Women's Committee, Dr. Amok Shahane Madam, Mumbai, Co-Chairman Maha-IAP, Dr. Kashmiri, Convener Maha-IAP Women's Committee, for giving me opportunity for presentation on this prestigious platform of Thursday Thrills. I also thank Dr. Sandhya Kondapalli Madam, Pediatric Endocrinologist, Sambhaji Nagar, for today's as a moderator for today's session, and Dr. Ujjwala Gowli Madam, Zonal EB member Sangli, who is the MOC for today's session. I thank both of them. Now, fever with rash, one of the most challenging, common yet a challenging presentation for pediatricians. We have rash with simple viral fever till to the life-threatening illness. We have find the cause of the rash is infectious, but non-infectious, the collagen disorders, autoimmune disorders, and drug reactions. And main thing we have to find whether the child is sick or the child is not sick. So let's start. Yeah, I can't. Yeah, just one second. Why this topic matters? Fever and rash is a ubiquitous chief complaint. It's a great imitator, a source of significant anxiety for families and a diagnostic challenge for clinicians. The rash itself is a often crucial window into the underlying systemic process. The objectives: develop a systemic step-by-step approach to evaluating child with fever and rash, master the key elements of history and physical examination to narrow the differential diagnosis, differentiate between common benign exanthems and life-threatening emergencies, and outline appropriate diagnostic management strategies. Now everybody know what is an exanthem and what is an enanthem. Exanthem is the eruption on the skin plus inflammatory changes, while enanthem is the eruption on the mucous membrane. This we have all seen right from the undergraduate days. What is a rash? What is a macule? Flat, well circumcised, discolored lesion less than 1 centimeters. A patch, large macule more than 1 centimeters. Papule, elevated palpable superficial lesion which is less than 1 centimeters, and a palpable plateau-like elevation more than 5 mm is diameter is a plague. Vesicle, small well-circumcised elevation of the skin containing clear serous fluid which is less than 0.5 centimeters. More than 0.5 centimeters vesicle is a bulla, and a pustule, small well-circumcised elevation of the skin containing purulent material. Petechiae are the small pinpoint less than 2 mm red non-blanching macule resulting from extravasated blood. Purpura are the large circumcised raised non-blanching patch or plague group of adjoining petechiae, and ecchymosis are the typically more than 1 centimeters in size and are caused by greater volume of extravasated blood than in petechiae. A wheal, transient raised with erythematous periphery and a central pallor due to dermal edema. A nodule, a palpable soft, a firm lesion in the dermis or subcutaneous fat, usually found in the dermal or subcutaneous tissue. Coming to the history and clinical examination. Initial assessment. The initial assessment, the sick or not sick child. This is the first and the very important question. Is the child toxic appearing? The red flags: lethargy or irritability may indicate central nervous system involvement. Poor perfusion, mottling, prolonged capillary fill, cold extremities suggesting shock. Respiratory distress, signs of severe systemic illness. And petechial purpuric rash requires immediate high priority evaluation. The rash fever dynamic, a clinical challenge. The vast differential from a simple viral exanthems to sepsis and vasculitis. The pattern recognition imperative your clinical eye is the most valuable tool. The morphology and distribution of the rash are the most significant clues. Importance of the timeline, the relationship of between the onset of fever and the onset of rash is critical diagnostic differentiator. We have seen right from the undergraduate days, the day of appearance of the rash with the various diseases. Day 1, varicella, scarlet, day 2, smallpox, day 3, measles, day 4, typhus, day 5, dengue, day 6, and typhoid, day 7. But now it may vary with the use of antibiotics, and so the drug rashes may vary according to the days. Epidemiological clues: diagnosis with fever with skin rash. Season: dengue is common in rainy season. Age of the child: Kawasaki disease is common in less than 5 years of age. Contact history: measles, hand, foot, mouth disease, chickenpox. Drug intake: Geographic location, endemic area of scrub typhus. Macular or maculopapular rash, measles, rubella, dengue, roseola infantum, erythema infectiosum, drug rash, adenoviral or enteroviral infections, infectious mononucleosis, chikungunya, HIV, secondary syphilis, brucellosis, scrub typhus, systemic onset juvenile rheumatoid arthritis, enteric fever, while a papillary is molluscum contagiosum. Vesicular rash, chickenpox, hand, foot, mouth disease, herpes simplex, herpes zoster, hemorrhagic rash, meningococcemia, dengue hemorrhagic fever, Hinox colony purpura, spotted fever group, gonococcemia, hemorrhagic measles, cutaneous vasculitis. Arterial rash, we find in allergic reactions to food, drugs, cosmetics, or soaps. Insect bites, environmental factors, latex, diffuse erythema with peeling or desquamation. We find in Stevens-Johnson syndrome, drug-induced toxic epidermolysis, Kawasaki disease, and staphylococcal toxic shock syndrome. History, the age is very important because measles are seen less than 3 years of age. Leptospirosis scarlet is seen less than 5 years of age. And between 4 and 10 years, we see enteric fever, varicella, rubella. The season, in the rainy season, we find dengue fever, leptospirosis, while in summer, we have rickettsial fever and measles in the spring season. History of exposure including insects, ticks, mosquitoes, flies, animals, and ill contacts. Contact with offending cosmetic agents, plants. Administration of vaccine or any other blood components which may cause reaction. Drug intake, topical and systemic anticonvulsants, allopurinol or NSAIDs. Immune status of the patient. History of similar illness in other family members. And family history of eczema and atopic dermatitis we have to find in allergic patients. Now coming to the examination. General appearance, vital signs, pallor icterus, involvement of the mucous membrane, conjunctiva, lymphadenopathy, presence of location, size, consistency, detection of hepatosplenomegaly, signs of knuckle meningeal irritation or neurological dysfunction. Characteristics of the lesion is very important. Duration, distribution, and progression of the rash, timing of the onset in relation to the fever, change in morphology such as papules to vesicles or petechiae, presence of primary lesion and secondary lesion and its pattern, presence of pain, pruritus, irritation we find in herpes zoster, associated symptoms with rash like fever, joint pain, abdominal pain, or other systemic manifestations, and prodromal symptoms. Now coming to specific conditions. Now coming to measles, rubella, the prodromal phase is 2 to 4 days, high fever, cough, coryza, conjunctivitis, Koplik spots, the tiny bluish white spots on the red brown inside the cheeks are pathogenic for measles. The rash is a maculopapular which appears on day 3 to 5, starts on the face, at the hairline, behind the ears, and spread downwards to the trunk and extremities. The rash fades in the same order it appeared. Measles, the complications, the common complications are otitis media, pneumonia, diarrhea, severe or encephalitis, a life-threatening inflammation of the brain, and immune amnesia. The virus can weaken the immune system, making the child vulnerable to other infections for an extended period. Rubella, the rubella rash is maculopapular rash, first appear on the face, then spread to the trunk and extremities, sparing palms and soles. Mild non-exudative conjunctivitis, small red spots, that is the Fortschimmer's spots may be observed. Congenital rubella syndrome, maternal rubella infection in the first trimester, nerve defects, CSD, cataract, saltpeter retinopathy, microcephaly, and hepatosplenomegaly, thrombocytopenia. Now coming to the rash of varicella. The varicella rash appears 24 to 48 hours after the prodromal symptoms. It's seen first on the trunk, initially pruritic erythematous macules. It's typically described as a dewdrop on rose petal appearance. Evolves into papules, clear fluid with vesicles, cloudy vesicles, and the crusted vesicles. Crops of lesion, simultaneous presence of skin lesion in varying stages of evolution is characteristic. varicella, progressive varicella syndrome, a dreaded complication in immunocompromised neonates, pregnant women, characterized by continuous development of lesions, hemorrhagic lesions, coagulopathy, and visceral organ involvement, including hepatitis, pneumonia, and encephalitis. Congenital varicella syndrome may occur following infection in the first and second trimester, characterized by skin scarring, malformed extremities, cataracts, and brain abnormalities. If the disease occur in mother 5 days before and 2 days after delivery, severe and often fatal neonatal disease may result. Dengue fever rash, we all know we are in the rainy season, we are coming across the dengue fever now. Dengue is a viral infection transmitted by mosquitoes, Aedes aegypti. The two phases are there, the febrile phase with a high-grade fever, facial flushing, myalgia, arthralgia, and the febrile phase rash is the onset of fever with a transient generalized macular rash develops. While second, the critical phase begins with the defervescence marked with the warning signs like intense abdominal pain, persistent vomiting, mucosal bleeding, clinical fluid accumulation, lethargy, and tender hepatomegaly. The second phase is associated with generalized morbilliform maculopapular rash sparing the palms and soles. Dengue hemorrhagic fever, dengue shock syndrome, the complication of dengue, the warning signs, abdominal pain, tenderness, persistent vomiting, bleeding, rapid breathing, fatigue, restlessness, irritability, cold and clammy skin. Now, next condition, coming to the next condition, this is erythema infectiosum, which is caused by parvovirus B19. We have high fever, fever declines abruptly and is followed by development of rash within 12 to 24 hours. The rash first appears on erythematous flushing on the face like a slapped cheek appearance, then rapidly spread to the trunk, proximal extremities as a diffuse macular rash with a central clearing to give a lacy or a reticular pattern. Rash fades over 1 to 3 period. Roseola infantum caused by herpes virus, HSV human herpes virus 6 and 7, high fever 3 to 5 days, respiratory symptoms, seizures. Rose pink rash appears on the trunk, then spread to the face, neck, upper extremities. It is non-pruritic, rarely becomes confluent and fades in 3 to 4 days. Red papules and erosions at the soft palate and uvula are characteristics. We all come across many patients of hand, foot, mouth disease in the OPD. It's a common viral illness by Coxsackie A16, but also by enterovirus 71. Fever, often the first symptom, sores in the mouth, painful blisters like lesions on the tongue, gums, and inside of the cheeks, rash on the hands and feet, non-itchy rash of red spots or small blisters, typically on palms and soles, and other locations. Rash may also appear on knees, elbows, and buttocks. The incubation period is 3 to 6 days. Symptoms usually last for 7 to 10 days and generally mild and self-limiting disease. This is you see the hand foot disease, the blisters. Papulovesicular rash on the palms and soles, less commonly on the buttock, genital, and knees and elbows. It's a chikungunya. The next condition, morphology and distribution of the rash. The rash is itchy, transient, maculopapular, distributed over the trunk and extremities, appearing 4 to 8 days after fever. High fever, rigors accompanied by intense joint pain, headache, myalgia, and rash. The arthritis is polyarticular, migratory, involving small joints. Laboratory diagnosis, virus isolation, immunofluorescence, and RT-PCR for genomic detection. Herpes simplex caused by HSV1, HSV2, single or group vesicles varying from 2 to 10 mm on a mildly erythematous basis. The primary infection, the first exposure can be severe with painful blisters, fever, and swollen lymph nodes. Oral herpes, small fluid blisters, cold sores on and around the mouth and lips. Genital herpes, sores around the genital anus and inner thighs. Prodrome, the tingling, itching, or burning sensation often precedes an outbreak. Herpes zoster, caused by varicella zoster virus. The rash is characteristic unilateral rash, often fluid-filled blisters that follows the dermatome. The most common location is torso, but it can occur anywhere on the body, including the face. The rash is painful, often severe. The rash is accompanied by severe and burning, throbbing pain. Rickettsial infections, we've seen a lot of rickettsial infections. The rash is macular papular consisting petechial. Typically, a painless ishar with a erythematous rim is the diagnostic. We see the ishar, that is the important. The common clinical pointers, common rickettsial disease in India are scrub typhus, spotted fever, Indian tick typhus, rickettsial pox. These are on the difficult infection to diagnose in their early course, and high index of suspicion is key to early diagnosis. Fever, rash, headache, myalgia, lymphadenopathy, epidemiological features, and history of exposure to vector are crucial for the diagnosis. But Isha is the main diagnosis for the rickettsial fever. Typhoid fever, the causative agent Salmonella, transmitted by contaminated water. We find typhoid fever in this rainy season, incubation period 10 to 14 days. Skin rash appears in the first week. Rose spots appear on the chest and abdomen. Pale red macules, blanchable. Other hepatosplenomegaly GI symptoms and arthralgia are present. This is the typical rose spots in typhoid fever. Leptospirosis, biphasic illness, divided into two distinct phases. The first phase, sudden onset of flu-like symptoms. Second phase, followed by the first phase associated with antibody production. The first phase is acute septicemic fever, myalgia, headache, conjunctival suffocation, GI symptoms, nausea, vomiting, and it lasts for 4 to 9 days. Second phase is immune. Symptoms may return after a brief period of remission. Meningitis, uveitis, eye inflammation, rash, a non-specific rash may occur. This is a rash with leptospirosis. Day before yesterday, only respected Dr. Nitin Shah sir have put a post regarding if you have waded in the rain, and so you are likely to have a infection of leptospirosis. And sir has put that post in the interest of the patients. So please take doxycycline 200 mg, OD, a single prophylactic dose. I've just seen 2 days before only. Scarlet fever, group A pharyngitis caused by pyrogenic exotoxin. Rash appears within 24 to 48 hours after the symptoms. Sandpaper-like generalized erythematous rash and a strawberry tongue. Begins around the neck, spread over the trunk and extremities. Diffuse, finely papular erythematous eruption producing bright and red discoloration of the skin which blanches on pressure. Epstein-Barr virus, the petechial rash at the junction of the soft palate and hard palate, maculopapular rash in 3 to 15% and in 80% who have received treatment with amoxicillin and ampicillin. Rash in meningococcal infection, it's a rash. Early lesions are macular, but rapidly increasing numbers of petechial or purpuric lesion. Location distal extremities, trunk, usually spans palms and soles. It is a life-threatening condition. Inoxalumin purpura, it's a small vessel vasculitis, palpable purpura in presence of at least one of the following 4 features: diffuse abdominal pain, biopsy showing predominant IgA disposition, arthritis, and renal involvement, any hematuria or proteinuria. Now coming to some drug reactions, we have Stevens-Johnson syndrome or toxic epidermal necrosis complex. This a spectrum of epidermal necrosis with designation dependent on extent of involvement of body surface area. Initial lesions are targetoid, followed by diffuse intense erythema, flaccid blisters, followed by large areas of denudation. Mucosal surfaces, oral, conjunctival, anogenital are also affected. A recent medication history, example, anticonvulsant, sulfonamides, NSAIDs, allopurinol, antihelminthics, antimalarial, corticosteroids, nevirapine, and lamotrigine may be reported. This is the spectrum of Stevens-Johnson syndrome, toxic epidermal necrosis. If the less than 10% of the skin is involved, it's Stevens-Johnson syndrome. If it is between 10 and 30%, it is Stevens-Johnson syndrome and toxic epidermal necrosis overlap. And if more than 30% of the skin is involved, it is toxic epidermal necrosis. Toxic epidermal necrosis, it's life-threatening, caused by the drugs, mycoplasma, herpes, erythematous macules, vesicles, villi, necrosis, and denudation of the skin. Now coming to other drug reaction, drug rash, eosinophilia with systemic symptoms, DRACE, we everybody know. Morphology and distribution of rash, the variants, articulated papular exanthem morbilliform erythema, exfoliative erythroderma. Facial edema is characteristics of dress, recent history of anticonvulsant or sulfonamide use, severe and potentially life-threatening, delayed hypersensitivity to drug reaction, distinctive triad of clinical and laboratory findings, while associated with fever, rash, eosinophilia, and atypical lymphocytosis. Cutaneous involvement and hepatitis typically occurs 2 or more weeks after the drug initiation. Kawasaki disease, it's a vasculitis and with the child under 5, leading cause of acquired heart disease. The diagnostic criteria in association with fever, we have bilateral conjunctivitis, oral changes, red, dry, cracked lips, strawberry tongue, redness and swelling of the hands, feet, following the peeling of the skin, and the rash is a widespread non-itchy rash on the body with cervical lymphadenopathy. Staphylococcal scarlet syndrome, we everybody see below the 5 years of age. Prodrome often begins with fever, irritability, and generalized feeling of being unwell. The skin may be tender and have wrinkled tissue paper-like appearance. Erythema, a widespread painful redness of the skin, often starting on the face or in the areas of friction and the groin and rapidly spreading. Flaccid blisters, large thin-walled blisters form on the reddened skin. These blisters are fragile and rupture easily. Skin slogging, the top layer of the epidermis peels away in large sheets, revealing a moist red, scalded looking surface underneath. Systemic lupus erythematosus, it's a chronic inflammatory disease. More than 90% of the cases of SLE occurring in girls. Fever, arthralgia, malar erythematosus, butterfly rash, photosensitive is the vasculitis rash. Now, these are the differential diagnoses based on associated with the clinical features for the diagnosis. Prodrome of upper dermal respiratory infection, measles, rubella, varicella, adenovirus, Coxsackie, Epstein-Barr. Fever with acute onset, measles, rubella, varicella, adenovirus, Coxsackie, infectious mononucleosis, scarlet fever, toxic shock syndrome, meningococcemia, bacterial endocarditis, leptospirosis, Kawasaki disease, systemic onset, juvenile chronic arthritis, and rheumatic fever. Fever of insidious onset, SLE, juvenile dermatomyositis, polyarthritis nodosa, Wegener's granulomacytosis, relapsing fever, Borrelia, Bordetella quintana, while polyarthritis of small giants myalgia, chikungunya fever, dengue fever, leptospira, systemic onset juvenile chronic arthritis, systemic lupus erythematosus, polyarthritis nodulosa, and arthritis involving large joints, acute rheumatic fever, hydroxyl purpura, hepatitis with lymphadenopathy, infectious mononucleosis, leptospirosis, Borrelia, and brucellosis, hemorrhagic manifestation, dengue fever, chikungunya, meningococcemia, and multi-organ failure, the severe conditions we see, which are dengue fever, meningococcemia, toxic shock syndrome, leptospirosis, and chikungunya fever. Diagnostic workup, tailor the approach to the clinical picture. Initial lab for the sick child, CBC with differential blood culture, CRP, ESR, electrolytes. Consider CSF analysis if meningeal signs are present. Targeted diagnostics based on suspicion. Rapid streptococcal test, throat culture for suspected scarlet fever. Viral PCR for HSV, enterovirus, or varicella. And serological acute and convalescent titers for specific viruses, measles, IgM, IgG. When in doubt, act fast. A septic workup is always appropriate for a child who is toxic appearing and or has a petechial rash. Management, symptomatic treatment, bed rest, antipyretics, adequate nutrition, fluid and electrolyte balance. Definitive management to be done as per the underlying diagnosis. Take-home messages, take-home points. The systemic approach is non-negotiable. A sick versus non-sick assessment is your most important clinical decision. The rash provides the most important clues. Look at the morphology and distribution. Laboratory studies can be useful in confirming the diagnosis. Potential causes include viruses, bacteria, spirochetes, rickettsia, medications, and rheumatological diseases. Always rule out the life-threatening conditions such as meningococcemia or Kawasaki disease. And up-to-date immunization history can save you and your family a lot of worry. Thank you.
Thank you so much, Dr. Sagarwak, for your lucid presentation and giving us the overview of all the common infectious disorders as well as etiologies associated with the non-infectious causes of fever with rash. And particularly thanks for the wonderful slides depicting the pictures of every rash and describing the important diagnostic clues. So it was a wonderful presentation on fever with rash, and I will request all the audience to put if any queries in the chat box so that we will discuss in detail and solve your queries at the end of second lecture. So thank you so much, Dr. Sagarwag. And now I will introduce our second speaker, Dr. Deepa Firke, madam. I will introduce her in short. Dr. Deepa Firke, she is
Thank you, madam.
having. Thank you.
Yeah. So,
That's okay. So, Dr. Deepa Firke, madam, she has done a fellowship in general infectious disorders. So, she is a right speaker for today's event, actually. She is professor and HOD at Department of Pediatrics in Government Medical College, Miras, currently. She is a National Central IIP EBM 2025. She is having a great experience of teaching experience for 23 years. Her area of special interest is pediatric infectious diseases. She is a postgraduate teacher for MD and DNB pediatrics also. She has 12 national and international publications. She is past president of Kolhapur Academy of Pediatrics. She is EB member MAHA-IP 2020-21. She is West Zone coordinator for MAHA-IP Women's Wing for 2022. She is West Zone coordinator for ICC module by Central IIP. She is faculty for so many IIP modules like BLS, BNRP, EPID, Fever 98.3 and so on. She is a coordinator for MAHA-IP Case Challenge. She is National Central IIP EB member 2025 and joint national coordinator for Pink Foods 202 Central IIP module, and she is organizing chairperson for Pearls PG training program. So with this vast experience, Dr. Deepa, we are eager to listen you on this important topic of dengue recent management. So over to you, Dr. Deepa.
Thank you, ma'am, for the kind introduction. Are you able to see my screen?
Yes, ma'am. It is visible. And full screen also.
Yes. So at the outset, I would like to thank our MAHA-IP President, Dr. Pakmode sir, our MAHA-IP Secretary, Dr. Amol Pawar, and of course, our Chairperson of MAHA-IP Women's Committee, Dr. Jaya Shivalkar ma'am, Amok Shahane ma'am, and Dr. Kashmiri for inviting me for this session today. And of course, I'm blessed to have Dr. Srinivasan sir, Dr. Gawani sir for this session. So yes, we are now in the monsoon and there are rains everywhere. And this is, I think, the perfect time for this talk. So today in my talk, I will be highlighting the updates, but as well as the routine dilemmas that we face when we are managing cases of dengue in children. So dengue, as we know, is a vector-borne disease and it has 4 serotypes. Any infection with one serotype renders lifelong immunity, but then if there is a secondary infection by another serotype, there is an increased risk of developing severe dengue, and that we know because of the antibody-dependent enhancement that occurs. So this is a very common diagram that every clinician knows. This depicts the different clinical phases of dengue infection. But then if we want to know in detail about the management, we need to still revise this diagram again. We know that the clinical phases include the febrile phase, the critical phase, and the recovery phase. Now, considering the critical phase, it usually starts by around 4th day and it lasts around 48 hours. But few things we need to keep in mind that the critical phase might vary from person to person. And the rate of leak might vary from person to person. And of course, we need to know that there are certain, in simple dengue cases, even the critical phase may not occur. So we need to know which are the patients which will go for a secondary dengue or for a severe dengue. So how can we know that? So yes, if we go for the serology, if we see in the serology, the primary infections that initial to start with, we have the viremias and the NS1 that comes positive. By around 5th day, it's the IgM, and IgG usually starts becoming positive at around 6th or 7th day. But if you see in the secondary infection, the IgG starts very early in the infection. So just by looking at the card, if we do the card test, we can definitely know whether it's a primary or a secondary infection. So if we have NS1 with IgM positive in the first few days, it's definitely a primary infection. But in the first few days, if we get NS1 positive with IgG positive, that definitely tells us that we are dealing with a secondary infection. Now, WHO has classified in 1997 the dengue in different syndromes, but then these are most of the times overlapping, and there were very confusing guidelines regarding the management of these syndromes. And therefore, in 2012, this classification was revised. And since then, the dengue has been classified into 3 groups, group A, B, and C. And as we already know, the warning signs which tell you about the leaky phase. If there is a warning signs, the warning signs are absent, it is group A. With the warning sign, it's group B, and group C is, of course, a severe dengue, which either comes with shock, bleeding, or an organ involvement, which since 2012, we are calling it as a expanded dengue syndrome. So if we are dealing with a child in a group A, definitely there are no warning signs here. So these are the children which we can very well tackle on the OPD basis. So we can advise them plenty of fluids, the rest and paracetamol, but those should not be exceeding 60 milligram per kg. Now, whenever we are advising the oral fluid intake needs to be prescribed rather than just encouraged. What do you mean by prescribed is you need to give them specific amount to be taken at a specific duration. So this is a simple method that we can follow. For an older children, if you advise, say around 3 glasses in the first 6 hours, 3 glasses in the next 6 hours, and then 2 glasses. So this comes to around 200 ml every 2 hours, and that comes down to just 50 ml every half an hour. So it becomes feasible for the patient and the relative to do it, and also it becomes easier for us to track the oral intake of these children. So many times, just prescribing supporting enough treatment is enough. We need to explain them about regarding the warning signs. But then there are certain patients who, even if they are in group A, they might still need an admission. So who are these patients? These are infants, obese patients, or patients having comorbidities like, say, diabetes, nephrotic syndrome, or a chronic renal failure or hemolytic disease. Because these are the patients which may rapidly progress into the critical phase, and therefore they need to be admitted even when they are not having any warning signs. So many times in our clinical practice, we see that the patient has a high-grade fever and some GP does an NS1 and it comes positive, and with the thrombocytopenia is referred to us. So now we have a dilemma, like how do we know whether this child is going to go for leaky phase or the critical phase or not? So do we have any indicators that would suggest that this child may be going into the critical phase? So yes, there are definite indicators. The first one is, of course, a sudden drop in temperature. We know that most of the infections, after the fever effervescence, the child becomes better or start recovering. But as against this in dengue, a sudden drop in temperature and a child becoming more sicker is an indication that this child is now going in the critical phase. The next is the leukopenia, the viremia that directly has an effect on the bone marrow and thus cause maturational arrest of the leukocytes, leading to a leukopenia. And this occurs even before the thrombocytopenia sets in. Next is thrombocytopenia. The thrombocytopenia usually starts before in the febrile phase itself, but then once the critical phase starts, there is an endothelial activation, and because of which there is a consumption of the platelets that occurs, and therefore there is a sudden drop in the platelets. So a sudden drop in platelets or platelet going less than 1 lakh is definitely suggestive that the child is going in the critical phase. And then next comes your hematocrit. We know that there is a leaky phase, so there is a third phase loss. So there is definitely an hemo concentration. But when we say that there is a rise in hematocrit, we need to know the baseline hematocrit of this child. And secondly, we need to also keep in mind that during the febrile phase, if the child is dehydrated, Still, he may be having a hemo concentration, but it is never to the tune of 20%. It is maybe around 5 to 10%. Sometimes, if the child has been admitted in the febrile phase and given a lot of IV fluids, the hematocrit may not rise up to 10-20%. So that we need to keep in mind. Then the bedside parameters that we always forget but are very important is a reduced urine output less than 0.5 ml per kg per hour, and of course a reduced pulse pressure. Then a direct evidence, this is an objective evidence for leak is a focus. Focus, that is the bedside ultrasound. And we had an excellent lecture by Dr. Lakkumar just 2 days back regarding how this is becoming a very important tool for the initial indicator of the critical phase. And it follows a certain pattern. So initially, to start with, it is around the gallbladder. It shows like a honeycomb appearance. And this is at the initiation of the critical phase. Then it goes to the Morrison pouch, or which is called as the hepatorenal pouch, by around 4 to 6 hours. Later on, it goes to the pelvis and the peritoneum by around 10 to 12 hours. And last is the pleural cavity. So first is the right pleural cavity, and lastly, it's the left pleural cavity where the accumulation takes place by around 18 to 24 hours. So this is a definite direct evidence, and is definitely we need to train our doctors in wherever the facility is available to see for this, because this may be a direct evidence of the leaky phase. And of course, certain biochemical parameters like albumin and cholesterol also may give you an indication that this child is definitely in the critical phase. Now, once we have confirmed that this child is in a dengue phase, in a leaky phase, now how do we go forward? So we know that the fluid management is the mainstay of treatment in dengue management, but then what is the fluid to be used, how much, how long, and when to stop? So these are the dilemmas that have been routinely faced by all the general pediatricians. So regarding the use of fluids, there were many studies regarding crystalloid versus colloids, and it has been shown that both are almost equally effective, but colloids are more do have more adverse effects, and therefore it's the crystalloids which are preferred. And amongst the crystalloids, it's normal saline or the Ringer lactate. Normal saline is usually the preferred solution, and especially when the child is having a hyponatremia or a normal chlorides. And if the child is having a hyperchloremia or a hypernatremia due to some cause, then RL is the preferred solution. Now, how much do we give? So this is a very important formula. It's the maintenance fluid for plus 5% deficit is the total fluid that has to be given over 48 hours. Why 48 hours? Because this is the average period of the critical, average duration of a critical phase in any person. Now, if the actual body weight of the child is either slightly less or slightly more than the ideal body weight, we can still use the actual body weight for calculation. But if the child is obese, then here we need to go for an adjusted body weight, and this is the formula for that. And we have to calculate the fluid as per the adjusted body weight. So let's take an example. This is a 7-year-old male child who has been diagnosed with a dengue in a critical phase now with a weight of 22 kg. Now the fluid required here is maintenance plus 5% deficit. So for the first 10 kg, it's 100 ml per kg. For the next, it is 50. And then for the next, it is 20 ml per kg. So it comes to 1540. And the deficit is 50 ml per kg. That is around 1100. So the total fluid required here is 2640. Now remember that this is the total fluid for the 48 hours. But then, as I already mentioned, that the duration of the critical phase may vary from person to person, and also the rate of the leak may vary from person to person. So therefore, the fluid that we calculate may not be maybe less for some patients, or maybe slightly in excess for some patients, but we need to titrate the fluid. So at what rate do we give? And this, see, remember this is just 1.5 ml per kg per hour. We have seen in our olden days that we were giving as high as 5 to 7 ml, but now the concept that has changed is the lesser the better. So it is 1.5 ml per kg per hour, and the solution that we give is 0.9% NaCl with 5% dextrose, because here the child is still not in shock. And then the subsequent rate of administration is titrated based on the pulse rate, the blood pressure, and the pulse pressure. And the most important bedside parameters are the urine output and the pulse pressure. So get up urine output every hourly, and based on the, try to maintain the urine output at around 0.75 ml to 1 ml per kg per hour. If the urine output is more than 1 ml, you have the fluid rate is high, so you need to you have to reduce the fluid rate. And if it is less than 0.75 ml, then this is definitely an inadequate fluid rate, and therefore you need to increase the fluid rate. And the pulse pressure has to be maintained around 30 millimeters of mercury. Now there's something called as watts. This is the volume on time scale that will tell you that whatever fluid that you have calculated, how much fluid you are given in the concerned hours, and this has to be kept around 70 to 80%. So the volume that will be required is around 70 to 80%. If you're constantly getting it around 60%, that means you're giving a lesser fluid. So here is when you might probably need a bolus to be given. If it is going more than 80%, say around 90, 95%, this is an indication that the crystalloids are not working, are not enough, and probably we might need a colloid to be given at this stage. And if it is going more than 100%, definitely this is a fluid overload, where it is an indication that we need to start with an injectable furosemide. So with this, with the vigilant monitoring of the fluids and the vitals of the child, we can definitely come out through the critical phase, and we need to look out for the signs of recovery. So what are the signs of recovery? So A, B, C, D, that is improved appetite, bradycardia sets in. This is a convalescent rash, already we saw in the previous lecture. It's described as a white islets in the Red Sea. And of course, the most important is diuresis. So you're trying to reduce the fluid rate, but still there is a diuresis, suggests that the child is now in the recovery. And of course, certain institutes might go for something called as immature platelet fraction, which is more than 10%. But this might not be available in all the facilities. So for a common pediatrician, we need to just keep in mind that if there are 2 consecutive platelet counts in a rising trend, that tells you that there is a platelet recovery that is going on and the child is in the recovery phase. And this is how most of the majority of your cases can be tackled in the critical phase without with just a judicious use of the IV fluids and monitoring of the bedside parameters. But then certain patients may come to you in the form of a severe dengue or in a shock. So these are the clinical features, and investigations suggest that this is a severe dengue. So we need to hemodynamically assess these patients. The conscious level, you need to check for the organ perfusion. So the conscious level will tell you about the brain perfusion, while the urine output will tell you about the kidney perfusion. The second, third, and fourth parameter, that is capillary refill time, extremities, and the peripheral pulse volume, will tell you about the peripheral perfusion. But the heart rate, blood pressure, and pulse pressure will tell you about the cardiac output. So depending on that, we need to evaluate whether this child is in a compensated shock or a hypotensive shock, because our treatment is going to change accordingly. So if the child is in a compensated shock, this is a scenario where we need to start with a bolus. Now the bolus here should be a small bolus of 10 ml per kg of crystalloids. If the child is not responding, we can still repeat the second dose. If still not responding, here's an indication where you have to start with a colloid, and that's the routinely used colloid is a dextran. If still the child is not responding, this child is definitely in a refractory shock, where you need to check for the reasons for the refractory shock. With the second thing, if the child is in an uncompensated or a hypotensive shock, the bolus that we give is slightly higher. It is 20 ml per kg of the crystalloids. And if the child, while giving the bolus, if the child responds, you can stop the fluid and you can go for the routine titration of the fluid rate as per the condition of the baby. But if the child is not responding, we need not go for a second bolus. We have to directly go for a colloid, that is dextran. And if the child responds, you can titrate the fluids. If the child doesn't respond, again, look out for the reasons for the refractory shock. Now, these are the certain dilemmas that we face when we are treating a patient of dengue, is when to use a colloid. So colloid is basically during management of shock, if the patient is not improving, even after 20 ml of per kg of crystalloids, this is the indication where we need to start with the colloid. Or if the child has already received a significant amount of fluid, so the quota that we had calculated, so already that is over, and still the child is not responding, here comes the indication that he needs a colloid. Or the child has come to you, already has received a lot of fluids outside. In such a case, we need to give the colloid. And the preferred colloid is, of course, dextran, because it's much cheaper than albumin and it doesn't leak out. And the dose is around 10 ml per kg per hour. and it is expected, once you give dextran, the expected fall in the hematocrit is around 8 to 10. But if there is a sudden drop on the hematocrit, we need to be cautious because probably we might be dealing with a concealed bleeding. Now, what are the indications of blood transfusion in a case of management of dengue? So basically, we need to suspect concealed bleeding when the hematocrit is decreasing, but the child is not improving. Rather, it's becoming more sicker. There is a persistent metabolic acidosis, or after giving your colloid, there is a sudden drop in the hematocrit. So in such cases, we are definitely dealing with the bleeding. So here we need to give a packed cell volume of 5 ml per kg over 1 hour. As soon as you give the blood, the hematocrit rises by around 5 points, but it takes nearly around 4 to 5 hours for the hematocrit to raise. We need to keep in mind that when the child is bleeding and the hematocrit is still very high, here first we need to give a colloid and then give the blood. Now, these are the complications that we routinely see in dengue. First is the profound shock. Whenever the shock lasts for more than 4 hours, it's called as a profound shock or refractory shock, which is not been responding to boluses of crystalloids and even the colloids. Then it's called as a refractory shock. Here we need to check for the ABCS. What is ABCS? Is a profound acidosis or a presence of bleeding, or there may be hypocalcemic or electrolyte disturbances and hypoglycemia. So you need to correct this so that the shock is taken care of. Then extensive bleeding. Now remember that bleeding is not secondary to the platelet count. Okay, it is mainly seen in patients who do have a profound shock, are at a higher risk of having an extensive bleeding. And we have already seen when to suspect a bleeding in a child. Fluid overload is usually, I would say, an iatrogenic complication. And basically, because of we are just pushing out fluids during the leaky phase. And the studies have shown that the more fluids that you push, the more is the leak. And therefore, in the recovery phase, we get this complications of fluid overload. And of course, a second infection, if there's a persistent fever, even in the critical phase, it might suggest a second infection and death. Regarding the something about the fluid overload, yes, the commonest signs in the early phase that you get is the child might start coughing or may have some periorbital edema or continuous diuresis. In the late stages, the child may have signs of congestive cardiac failure or breathlessness. So here, if there are such signs, then we need to check how is the intravascular volume. If the intravascular volume is depleted, you directly cannot give furosemide because that may be detrimental for that child. So first you need to give a bolus of dextran, then followed by furosemide. If the intravascular volume is good, then you can directly go for a IV furosemide. But the dose here, remember, is lesser. It's just 0.1 milligram per kg as and when required. So these are certain don'ts that you should be doing you should not be doing rather in the management of dengue. Never use hypotonic fluids. Prophylactic platelet transfusion has no role. The studies have shown that it neither prevents nor reduces the bleeding in the dengue patients. No role of steroids and IVIG. Rather, steroids may cause an increased risk of bleeding. The other factors that have been used for reducing bleeding, like tranexamic acid or the factor 8 or FFP, are also have a very are less efficacious and therefore should not be routinely used. And inotropic support is routinely not necessary, but if you are having a refractory shock and if you think that even there's a myocarditis in this patient, in such patients you might require an inotropic support. Now, this terminology is coming up is the expanded dengue syndrome since 2012. We have seen that in the severe dengue cases, there's an organ involvement that occurs, and this may come with or without the leaky phase. So this involves many common organs, like the most commonly involved is the liver in the form of either hepatitis, acalculic cholecystitis, or pancreatitis. Kidney may be involved either because of the hypovolemia, that is acute kidney injury, or there may be a hemolytic uremic syndrome. We are also seeing many neurological complications, and encephalopathy may be secondary to a metabolic, maybe secondary to the liver pathology or hypovolemia. Meningoencephalitis, seizures, and polyneuropathies like a GBS-like syndromes are routinely seen. Cardiac manifestations like myocarditis, rhythm disturbances, and of course pulmonary and hematological involvement is also seen. One of the upcoming complication is the hematological, that is the secondary HLH. Now, secondary HLH is a very fatal complication and is characterized by a hyperinflammatory state. But we need to remember that the child should fulfill all the criteria that are required for HLH to label it as HLH, because the criteria like cytopenias or a hyperferritinemia may be routinely seen with a simple dengue case also, because we have leukopenia as well as thrombocytopenia. So bicytopenia is routinely seen in simple cases of dengue, and a raised ferritin because it's an inflammatory marker can be routinely seen. So just based on the ferritin levels or the cytopenias, we should not be labeling this child as an HLH, but it should fulfill all the criteria. And here, once it's been confirmed that this is an HLH, then there is a role of either IV, IG, or corticosteroids that can improve the outcome in these patients. As mention about dengue in infants, because these infants do have a very short duration of the critical phase, and it may be less than 24 hours, and in some infants it may be even just 6 hours. And of course, we know that they have a very less respiratory reserve, and therefore these infants are at a great risk of fluid overload, and hence the use of dextran may be considered early in treatment of infants. Now, regarding certain other updates, there are various research going on, and they are trying to target the viral proteins and as well as the host proteins, so as to develop certain drugs which might act against the dengue virus. But still, there is no specific drug in market. Certain drugs which were already been used for other purposes like chloroquine, loastatin, ivermectin have been tried, but still at present there are no specific drugs against dengue virus. And a word about the anti-dengue vaccines. We know that since last decade, there are many dengue vaccines in the pipeline. There are 2 of them which are now being used. One of them is Dengue Vaxia, which has been used since 2015. And the other is the Takeda vaccine. But the main problem with the dengue vaccine is these are the quadrivalent vaccines, but then it should be equally efficacious. There should be an equal seroconversion of all the serotypes. If this doesn't occur, then the child is at risk of having an infection with the virus, and the infection that occurs may act as a second infection, and the child may be at a risk of having a severe dengue later on. And therefore, the Dengue Vaxia that has been recommended is recommended only for children from 9 to 16 years who already have lab confirmed dengue infection. So yes, there are still more researchers to go on to come up with an ideal dengue vaccine. So to just sum up, the golden rules, whenever we are treating a child or managing a child of dengue, we need to be more proactive rather than reactive. And the golden rules of management are: we need to identify the beginning and the end of the critical phase. There has to be a meticulous monitoring and the titration of the fluid as per the rate of the fluid leak, so that we give sufficient amount of fluid to manage the organ perfusion, neither too less to cause profound shock, neither too more to cause a fluid overload. And of course, anticipation and early detection of concealed hemorrhage and other complication is necessary, and to manage it at the earliest. And of course, to identify the atypical presentations of dengue. Thank you so much.
Thank you, Dr. Deepa, for a
Excellent
wonderful presentation. Really, it was an
Superb.
excellent presentation describing all the phases of dengue, how to identify the start of the critical phase, actually how to identify the danger signs, what are the danger signs in dengue shock. There were very good cases to teach us how to scale the fluid management and how to titrate the fluids, types of fluids, how to identify and manage the dengue shock, parameters of the shock, also the indications of crystalloids, colloids, blood transfusion, and various complications and the recent advances in dengue fever. Really, with very crisp presentation, and thanks for limiting both the lectures within a specified time. So it was really a very academically wonderful session, today's session. And the thing to mention is there is a wonderful attendance also, and all the audience are still on the platform. So congratulations, Dr. Deepa and Dr. Sagar, for
Thank
the
you, ma'am.
presentation.
Thank you.
It was a very
Ma'am, there are two questions in the chat box.
yes.
Yes.
Thank you, madam.
There are two questions in the chat box. Deepa ma'am, we want to ask whether maintenance fluid should be calculated for 24 hours or 48 hours along with 5% deficit, which is given. So one of the viewers wanted to know about it.
It is a maintenance fluid for 24 hours plus the 5% deficit. And this is a total fluid to be calculated over. This is for the 48 hours, that is the critical phase.
Okay, ma'am. And there is one more question is, madam, how do we interpret the dengue IgM weak positive on dengue kit?
So dengue IgM weak positive may, if it is without an NS1 positive, then it may be just a recent infection, because we know that IgM starts appearing at around 4th day and may remain there for around 3 months.
Yes.
So if there is NS1 is negative and the IgM is weakly positive, probably we are dealing with a recent infection and not an active infection right now.
Okay, thank you, ma'am. And over to Dr. Sandhya, ma'am.
Thank you.
Yes. Any questions from the audience?
Can I ask one question? This thing?
Yes, sir. Yes, sir.
Yes.
Sure.
Yeah,
Yes.
no, sir. I am Srinivasan, still a student. Just I wanted to ask, any experience of neonatal dengue, because from Erode on Dr. Selvan has seen so many cases of neonatal dengue and chikungunya. The mothers had and then these children had. Any experience of dengue from any one of you in neonates?
So we had one case where the mother had dengue and the child also showed some signs of shock, but unfortunately we lost that child because
Yeah, they are very serious, and of
within
course,
5 hours we lost that child. So this child had presented in shock.
yeah.
That was only one case I've seen, but not routinely seen.
Thank you.
The only thing we need to keep in mind is that the critical phase is very short in infants, and therefore we need not give the whole fluids. We have to be very careful and
Of course, in newborns, we have seen chikungunya transferred from mother, and they had developed myocarditis and they had died before treatment.
We've seen cases of chikungunya, so they're like typical that rash and blackening of nose. But I've not seen much of neonatal dengue cases.
If they are not coming in the critical phases, I think means most of the neonatal dengue behave in the benign fashion. If they are not coming in the shock, even with the severe
most of the times,
thrombocytopenia,
because the closest differential is a sepsis. So
closest differential
probably
is
we might be
sepsis.
facing and we might be not doing an NS1 in these patients, and probably we might be missing the shock because of dengue.
Because of thrombocytopenia, we think of sepsis only first.
That is what. Because thrombocytopenia may be seen in sepsis also.
Sepsis also. So in neonates, we correlate with sepsis only.
Yes.
So, Dr. Deepa, I want to ask one question. You said there is no role of FFP. Yes, but if the situation is like that, APTT, usually previously we used to decide the severity of dengue illness based on APTT.
Yes.
So if APTT is prolonged, maybe like more than 45 or 50, and the child is bleeding, there is no much significant thrombocytopenia. So are we justified to give FFP in sepsis?
Yes. In case routinely, if the child does not show any deranged coagulation profile, there's no role of FFP. But as you said, if there's liver involvement and definitely the coagulation profile is deranged, then there's the role where. But routinely we say that FFP is routinely been given. So that should not be the case. So if there's an indication that the coagulation profile is deranged, definitely there's an indication of FFP.
Yes, and is it like that the deranged coagulation profile itself is an indicator of severity of the disease?
Yes, of course. I've shown certain indicators of severity. So deranged, like very high LFTs, increased LDH, then very low hypoproteinemia. These are all indicators of a severe dengue.
Yes. Any
I
other
request
question?
Dr. Sandhya ma'am to please present the vote of thanks.
Yes. It's a very sweet role.
Ma'am, two questions asked.
Yes. Any question? Any more question?
Here, two questions are there about the
Yes.
kit only, weak positive.
Yes,
Which posted, ma'am?
positive, I think she explained.
I have
been
answered.
answered.
Yes.
They have been answered.
Yes. Both the questions.
Shall we consider it as a weak positive, as a false positive due to some other viruses?
Yes, I have never read that there may be some other viruses which may cross-react to give a dengue IgM positive. But as I said, it may be a recent infection. And that's not an acute infection, but a recent infection, because of which probably the IgM is now lowering down at around 90 days. And that's when we get weak positive IgM.
Okay. Okay, thank you.
But in all the kits we get, madam, weak means interpretation as a weak, or in the few kits we get interpretation as a weak positive. Because few pathologists I have seen, they are reporting either positive or negative. They are not reporting weakly.
Yes, sir. In periphery, we are getting this routine problem. And how to interpret it? As
I think so.
So you have to
problem.
clinically correlate, sir. Basically,
Yes.
as we suggest that we need to
All
clinically correlate whether it's really a case of dengue. So if there are the other clinical features that are suggestive, then you might still consider it as a dengue. But clinically, if you're not getting any signs suggestive or any symptoms suggestive of dengue, and only IgM negative should not be the only reason for the child to be started with any fluid management.
There's one question whether the ELISA or CAR test is, which one is the gold standard? I think so. ELISA is the gold standard test for
That is always a gold
dengue.
test. We can keep
Even
on monitoring these
flaviviruses are
patients.
known. Even flaviviruses are known to have cross-reactive IgM positive, so it can cause past infections where the titers are weaned.
So ultimately, we need to clinically correlate and then decide.
Yes.
We have seen the cases also. The first they do not come positive for 2 to 3 days, and afterwards, then they come positive for NS1 or the IgM. But
NS1 usually is positive in the first day, so it peaks by around 4th day and then disappears by 9th day. While the IgM starts at around 4 to 5th day.
4 to 5th day.
If you do an test at around 4 to 5 days, there are chances that the NS1 as well as the IgM is positive. IgG is still yet to come. So you have to do the test at around 4 to 5th day of fever and not before that.
Yeah.
Very
when
early
we report this,
when
we report these NS1 positive cases to the authorities,
yes,
they don't when they don't take it. They say unless and until it is IgM positive, will not enter in her.
Yes, for the practical purpose, we are taking because NS1 does have a very good sensitivity, especially in the primary infection, around 90%. And but again, we need to remember that NS1 negative does not rule out dengue. Also,
that is the thing. NS1 negative does not rule out dengue.
It also depends on when you have done it.
Okay. So I think we have completed with all the queries, and we are at the concluding time of today's session. It was really a wonderful presentation by both the speakers, and they have given full justice to their topics. So I will like to thank Dr. Sanjay Pakmode sir, our President Maha-IP, and our Secretary General Dr. Amol Pawar sir, to giving us opportunity to arrange such a wonderful clinical program. I will like to thank Dr. Jaya Shivalkar madam, who is our beloved chairperson of Maha-IP Women's Committee. I will like to thank Dr. Ujjwala Gauri madam, being MOC and helping us a lot in today's session. I will like to again thank and congratulate both the speakers, Dr. Sagar Wagh and Dr. Deepa Firke. At the end, I will like to thank for the technical support by Pallavi Madam, and thanks to all the audience to be with us till the end and to have an active participation for today's session. Really, it was a very, very, very good program. Thanks again. Thank you so much.
Thank you,
Thank
Sandhya
you.
ma'am.
Thank you all.
Thank you,
all.
madam.
Thank you so
Thank you,
much.
Sandhya madam.
Thank
Thank
you,
you,
Deepa
Ujjwala
madam,
madam.
Ujjwala madam.